to each and everybody, those who are present here and those who have connected us through our Code Connect Live platform. I, Piyush Shukla, on the behalf of Corona Remedies, welcomes you all on the 18th edition of Searchlite, based on updates on mid-trimester anomaly scans in association with Hassan, Haveri, Jalna, Bhimavaram, Jaipur, Jamshedpur, Jhansi Obs and Gynae Societies, and SFM Chhattisgarh. We again invite you to all to this auspicious occasion. And as per the tradition goes, I'd like to introduce you all with the convener of today's program, Dr. Sujaya Sri Sangitama. The lady needs no introduction, but yet I'd like to mention few of her many achievements. She is consultant obstetricians and laparoscopic surgeon to Sheshadri Hospital, Palakol, Malikapuram. She is founder secretary to Bhimavaram Obstetric and Gynecology Society, secretary IMA Palakol. She has been awarded by Shan S. Ratnam Young Gynecologist Award, Foxy Dhia Award, and many of the awards under her name. She has various areas of interest, two of which are laparoscopy and infertility. A very warm welcome, ma'am. I'm handing over the session to you. Please, ma'am.
Thank you so much, Mr. Piyush, for that kind introduction. So I take the program forward. I would like to introduce the
Piyush, I think her video is frozen. Would you just proceed with the lamp lighting, please? And then we can take it forward. I can be introduced later. Namaskar, everyone. We would initially take the blessings of the divine before we proceed with the program. So please join us in the lamp lighting and Ganesh Vandana.
वक्रतुंड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देवा सर्वकार्येषु सर्वदा।
Namaskar. On behalf of Searchlight 18, I would like to welcome all the respected faculty and the delegates who have joined this webinar. I welcome and thank Hassan, Haveri, Jalna, Bhimavaram, Jammu, Jaipur, Jamshedpur, and Jhansi Obstetric Gynec Societies and Society of Fetal Medicine Chhattisgarh chapter who have kindly agreed to join me with this webinar. The program is focused on mid-trimester anomaly scan. It is not actually a program like the Society of Fetal Medicine does it. It is looking at it from the gynecologist perspective, what we need to know so that we can serve our patients better. So I would like to introduce the chief guest of this evening, Dr. Jayam Kanan ma'am. She's an emeritus professor, Tamil Nadu MGR Medical University. She was VP Foxy 2018, and she is an academician par excellence, a teacher of teachers, And before I read this proper CV, what I would like to tell is that we had invited her to Raipur for paper judgment, actually for an oration, and also requested her to judge the papers. He was so kind to the students and so loving, and without criticizing, she has taken them the right way. It actually opened my eyes to what a teacher should be. So, welcome, ma'am. Though she has many achievements, she has the President of India Medal for Outstanding Performance and Best Book in Medicine Award 2 times from Government of Tamil Nadu, Best Society President Award, Best Society Secretary Award, Best Book in Medicine Award, Lead Assessor and Exceptional Commitment, Distinguished Service Medal 2018, first Indian to receive the RCOG Award. She has so many awards and everything, but more than that, she's a gem of a teacher, always there to guide us whenever needed. Ma'am, this topic is dedicated to the better health of babies. I seek your blessings for this webinar.
Much, dear Asha. First time about a few years ago, I think it was in 2018 or 19, when Pradeep Tambe came and told me, Asha Jain wants to meet you. I was so much shocked because at that time and all, Asha from Chhattisgarh is known for her academics, known for her perception, known for her depth of knowledge, and known for her strict way of conducting the questionnaires. And they said like that, I just ran in the hall to find out where Asha was. And after that, for the first 5-6 years, my journey with Asha has been so good, so nice, so academic that in the last 3-4 years, I am spending easily 2 days on the entire pre-paper and poster session along with other judges. And we have made Chhattisgarh society go away from case presentation to research data presentation. In the last year, there was no case presentation. They all came with study reports. Study of 25 cases, study of 500 cases. Chhattisgarh with its Society and Fetal Medicine, Haran in her room last year, since I am also involved in ultrasound for the past 40 years, and I am having the Vipro 10 machine. So with this ultrasound, the knowledge which she expects from all the faculties, from all the chairpersons, and all the panelists also has to be at a very, very high end. I'm very sure that the speakers and the topics which has been selected has been so good. And this is going to be a different ultrasound program. As Asha said, it is an ultrasound program for gynecologists, not for ultrasonographers. Ultrasonographers can just say the message and get away with it. But we have to face the patient. They may give the report on a Saturday night, 9 o'clock, and the patient will be promptly there at 9:45, 10 o'clock in the gynecologist clinic, demanding her presence and giving the explanation, because next day, Sunday, she cannot sleep unless she knows what is going on with her baby. That is what a gynecologist reading the ultrasound means, rather than a radiologist or ultrasonographer reading the report. The ultrasonographer at least could have called the gynecologist and told her, Madam, I have seen this problem. What should I do with the patient? Gynecologist knows whether it is an emergency or it can take some time. But when the ultrasonographer gives a paper saying that such and such anomaly is detected, finished. They may have even seen the small radio-opaque shadow in the heart, which is there in all Asians. Finished. 10 o'clock in the night, you have to be there. Otherwise, your hospital goes to be torn to pieces. So she has taken a very nice program, and this is going to be an eye-opener. I'm very sure I'll be able to be here, hearing all of you. And if possible, now and then I will join and give my piece of knowledge which I have on this great subject which has come up a lot because nowadays we are not waiting for a scan at 20 weeks, even though government has permitted up to 24 weeks for termination of pregnancy. Nowadays, we are trying to look at 8 weeks, 10 weeks, even 11 weeks, not even going to 12 weeks, so that the procedure, the process of termination of pregnancy goes without a lot of stress for the patient, for the gynecologist, as well as for the uterus for the future. With these words, I pray, bless all of you for a very prosperous future and bless Asha Jain for a lovely outcome in Foxy with all her heartful, brain full of knowledge and prosperity to the 43,000 Foxians, which is presently the number which is there in Foxy. Thank you very much, Asha. Thank you very much, Bimal, Sujashri, and others who have been here to hear. Thank you very much. Thanks to
Thank you
Aditi.
so much, ma'am. Thank you so much.
Ma'am, do I get to introduce you? We've missed out that because of my
Wait.
poor network.
After that, we'll do that at the panel, dear.
Okay,
So,
fine.
may I have Bimal sir's CV? So, Dr. Bimal Sahani sir is the director, Sonoscan Center, Aurangabad. He is the immediate past president, Society of Fetal Medicine, deputy editor, Journal of Fetal Medicine, academic coordinator, scholar MD2 Medicine Training Program. He's an MD in radiology and is a faculty at various national and international conferences. His areas of interest are fetal growth and Doppler and fetal echocardiography. Is the co-author of second trimester guidelines of Society of Fetal Medicine. He's the author of chapter Transposition of Great Arteries, Heterotaxy, Anomalies of Pulmonary and Systemic Veins, Umbilicoportal Systemic Shunts in IRIS Textbook of Clinical Radiology. He is also the co-author of SFM India-Oriented Guidance Statement for Ultrasound Establishments during the COVID-19 pandemic and co-author of SFM Interim Practice Recommendations for Zika virus infection in pregnancy. So I've known sir since I started working in fetal medicine and attended my first workshop conference at Leela in Delhi. A very humble, very knowledgeable person, and he will put great points across almost effortlessly. So welcome, sir. We seek your blessings to this webinar.
Thank you very much for those kind words, and thank you very much for giving me the privilege to be the guest of honor for such a wonderful meeting. The topic itself, anomaly scan, and yes, we have always related anomaly scan to the mid-trimester, but now the times have changed. We are looking for anomalies at every scan, right from 11 to 14 weeks, and even during the growth scan. So, but then, yes, we know that mid-trimester is the best time to screen, and not just picking up, it's very important for everybody, right, from the people performing the scans and the clinicians to also know that the mid-trimester, when we do the whatever we call it as a TIFA scan or anomaly scan, actually that is screening for structural abnormalities. And generally everybody expects that, yes, by the time we have finished the 20-week scan, then we need to get a final answer whether this baby is normal or not. But then we also know there is enough evidence from very good centers that about 15% of anomalies would be detected late in the third trimester, that these are the evolving anomalies, and 10% would be detected after birth. Hence, it's very, very important that all of us are well versed with this entity, that yes, the mid-trimester scan is the best time, but then you could still, there could be still a lot of anomalies which could be picked up later on. Some maybe because they're evolving, some are too late onset, or some primarily they were not apparent at the time of the mid-trimester scan. Your second topic of soft markers. Now, soft markers for years have given us a lot of pain. And there has been a time where, because there was no clarity on the significance of these markers, a lot of fetuses have been terminated because of soft markers. But we have evolved over a period of time. We have enough evidence that a lot of these soft markers are actually very soft, in fact, and they really do not increase the risk much. And in the era of NIPT and the first trimester screening becoming a part of the protocol, I think a lot of these soft markers second trimester they're not losing significance, but definitely the panic that we used to have with this has definitely come down. And you've got two very good speakers who will take you through, both of them very good friends of mine, Dr. Reema and Dr. Rachita. And I'm very sure that by the time they finish, a lot of you would be quite well versed with what to do with these soft markers. And in fact, an anomaly, when a report with an anomaly scan comes to the obstetricians, how should they interpret it and how they need to explain to the patients. So thank you very much, Asha madam, and thank you everybody from the team for having me here, and my best wishes for this wonderful webinar, and happy learning to all. Thank you very much.
Thank you so much, sir. Thanks a lot. So, Dr. Ajay Manu will be joining us at 6 o'clock. He's traveling right now. So, we would proceed with the scientific session now. We would take Sir's CV when he joins in, which will be around 6 o'clock. We start with the scientific session. And requesting Sanjaya, would you please introduce, dear?
Yeah, moving forward to the session where the topic is positive soft markers at mid-trimester anomaly scan. What next? So firstly, I would like to introduce the chairpersons of today's session. We have Dr. Surekha Handral with us. She's the president of Haveri OB-GYN Society. She is a consultant at Handral South Danya Hospital at Haveri. Welcome to today's session, ma'am. Next, we have Dr. Smita Kulkarni. Madam is a consultant endoscopic surgeon and infertility specialist. She is the president of Jalna OB-GYN Society. Madam, welcome to today's session. I request one of you to please introduce the speaker.
Hello.
Yeah, ma'am, please.
Yeah, sure. Madam, you want me to go ahead?
Yeah, please do, ma'am, please.
So, hello everyone, and I am so happy to join, and it is going to be an excellent webinar. So today we have Dr. Reema Bhatt. She is the specialist professor and head of fetal and medicine perinatology at Faridabad Amrita Hospital. And I'm very happy to have her here because she has a lot of achievements. She is a senior advisor in Army Hospital and Referral Center for 9 years, National Secretary of Society of Fetal Medicine, National Advisory Board for Journal of Fetal Medicine. So we are going to have really very good inputs from her. She has special interest, especially in fetal invasive therapy, and she has a lot of publications in her name on national and international journals, and a lot of awards also, especially President's Award for Meritorious Service in Armed Forces, Chief of Army Staff Commendation. She has received gold medal on 42nd Annual Conference of our Foxy Delhi, Veera Agarwal's medal on Best Paper. So we are very happy to have her here. Hello, welcome, madam.
Thank you so much, ma'am, for your kind words. So I've been given a very interesting topic of soft markers that is intrigued, I think, all obstetricians and fetal medicines alike. Is my screen visible?
Yeah, you can make it a full screen, ma'am.
Yeah.
Hello.
Yeah, it's visible now, ma'am. Yes.
Yes. So I get you greetings from Amrita and blessings from Amma. So we really don't know whether the soft markers are actually game changers or are they false alarm. So the question is that in the era where we have very good screening protocols for looking for Down syndrome, where we have a first trimester screening protocol, which gives us a detection rate of almost 90 to 92%, is there any role of soft markers in today's screening for Down syndrome? We have 4 potential roles. Wherever there is high risk on first trimester screening, which is borderline positive, patient does not want to go ahead with any other further screening, borderline negative, twin pregnancy, where patient has come to us only in the second trimester, we've lost the opportunity of the combined first trimester screening, or all pregnancies where the combined first trimester screening was not performed. So genetic sonogram is only an alternative, is not clearly has a defined role for screening for Down syndrome. Now, what is a soft marker? There are features that are detected on the second trimester ultrasound. Whenever they are present, they modify the a priori risk for aneuploidy, although they are not diagnostic for a condition like Downs. They're present in 11 to 17% of euploid fetuses, and it is increased prevalence in aneuploid fetuses. We must remember that they are transient. They resolve with increased period of gestation or with birth. They have no clinical sequelae, and prevalence of aneuploidy definitely increases when more than one marker is present. So there's nothing that we need to be scared about. So are there any recommendations? There are no uniform recommendations as far as soft markers is concerned. In 2020-21, Society of Maternal Fetal Medicine has modified its previous recommendation that came up in 2013 and 14. The meta-analysis for the second trimester ultrasound by the Nicolaides group that came up in 2013 has stood the test of time. And this is what we use as the base when we need to counsel our patients regarding soft markers. So all these soft markers have, they're few in number. Some of them are more important than the other. But what we need to know that they have a positive likelihood ratio and also a negative likelihood ratio, which ultimately gives us the isolated risk of a particular marker that gives a screening performance for Down syndrome. So what we need to understand that these markers, whether they increase the risk of Down syndrome, whether they have no impact, or whether they increase the risk of other conditions other than Down syndrome. We need to answer these three questions when we are dealing with any soft marker that we read on the anomaly scan. We need to understand that certain markers like ventriculomegaly, increased nuchal fold, echogenic bowel, hypoplastic nasal bone, they have a slightly increased likelihood ratio compared to the other markers. And I would take you through different case scenarios as to how they're important in clinical practice. So every patient has a baseline risk. That's the a priori risk, which is either based on the age or based on the combined first trimester screening. But we have seen cystic fibrosis also being associated with echogenic bowel. Possibility of infections like cytomegalo also goes up. There could be evolving GIT problem. There could be intestinal atresia. There could be meconium peritonitis. And lastly, if all of this is normal, there are still chances of fetal growth restriction in the baby. So what we would ask for our patient would be karyotype or a microarray, which is definitely the test of choice. We do CMV, PCR serologies for the mother. Amniotic fluid, we look for PCR for the infection. We can do cystic fibrosis carrier status for the parents. And definitely, we need to follow up the baby for fetal growth restriction. And what about the dilatation of the kidneys? Well, we have a UTD classification. So as far as Down syndrome screening is concerned, we add the likelihood ratio and we tell our patient that, okay, this is a risk for Down syndrome. But additionally, when we have markers like echogenic bowel or we have the renal pelvis dilatation, we need to tell them that there is a possibility that this dilatation of the renal pelvis could increase over time. So if the patient is currently in urinary tract dilatation A1, it can progress to UTD A2-3. We need to follow up this baby. We could be looking at pelvic junction obstruction. We could be looking at vesico-ureteric reflux. So when counseling for the patient is happening, it's not just for aneuploidy. We're looking much beyond. So when we have this marker like the renal pelvis dilatation, we need to assess at 32 weeks if the dilatation is about 4 to 7. If more than 7 at 32 weeks, a postnatal follow-up is required. But yes, some form of screening for aneuploidy should be in place, even if it's an isolated marker. We should have had at least some cell-free DNA, at least a quadruple test if the patient cannot afford a cell-free DNA, and we need to follow up for the renal pelvis dilatation. So this patient underwent amniocentesis, chromosomal microarray was normal, infection screen was negative. We did not test for cystic fibrosis. Patient didn't want to invest money in that. We increased fetal surveillance for growth restriction. She developed FGR at 30 weeks, and we delivered a 2 kg baby at 32 weeks because of FGR and deranged Dopplers. So echogenic bowel actually translated into FGR with everything else being normal. Now, coming to our next case, I had a 40-year-old patient, G2P1. She had an ultrasound at 21 weeks where her trisomy risk was 1 in 82. Now, that's a high risk, but her negative genetic sonogram, there was no marker on the ultrasound. We need to remember that when we do a genetic sonogram, the detection for Down syndrome is only 60%. Only 60%. So when a patient asks you that if my genetic sonogram is normal, is my baby going to be chromosomally fine? We need to tell them that we've done an ultrasound, there is no marker, but the detection rate is only 60%. Her risk, likelihood ratio, when everything is absent, comes down, and her post-test risk of genetic sonogram was 1 in 630. So where we started with 1 in 82, where we would definitely push the patient for invasive testing, we went down to a risk of 1 in 630. But even if the patient gets an NIPT done, we are happy with the NIPT reporting. If an IVF patient comes to us, she definitely does not want an invasive testing. Here, again, genetic sonogram plays a role. But if everything is normal, it gets down her risk. Now, this patient came to us with a combined first trimester screening, which was 1 in 280. Now, this is borderline negative. 1 in 250 is the cutoff that we take. So if the patient comes to us as 1 in 280, it is borderline negative. We did a generic sonogram and there was increased nuchal fold thickness. Now, we've said that increased nuchal fold thickness has a likelihood ratio which is higher. It is almost 3.79. That is 4 times higher risk of having Down syndrome if nuchal fold thickness is increased. We did an amniocentesis. It was amniocentesis because she was of advanced age and she came out to have a deletion in 22 chromosome. So what I want to again highlight is that genetic sonogram, soft markers have their limitations. What stands the test of time is doing a better test, that is either a combined first trimester screening or a NIPT if patient can afford. So soft markers are just features that are detected during the second trimester ultrasound. They modify the a priori risk. Detection of one marker should prompt you to look for other markers. This patient deserves a fetal medicine referral, and workup is extremely important. I again reiterate the markers that you must send for fetal medicine referral is ventriculomegaly, increased nuchal fold, echogenic bowel, or absent or hypoplastic nasal bone. But if the patient comes to you where a cell-free DNA is done, we do not change the a priori risk of the patient because it's a very good test that the patient has undergone, and we really do. We can just mention in the report that there are soft markers present, but they don't change the risk for Down syndrome for the patient. Now, ventriculomegaly is also something that I wanted to talk about because we very routinely get patients. First of all, the image should be of good quality. If you have a ventricle that is more than 10 to 15 millimeters, we need to look beyond aneuploidy. It's just not the possibility of a chromosomal problem. There could be some CNS problems, there could be some infections, or there could be some maldevelopment that is going to show itself later in pregnancy. So we had this patient who came to us with ventriculomegaly, borderline 11.1. We did a CNS neurogram. The corpus callosum was good. CNS was all good. We offered karyotype that was normal. Infection screen was normal. We did an MRI also. Everything was okay. The ventriculomegaly went up to 12 to 13 millimeters. But since we tested the patient, we could reassure things are going to be fine. She delivered a normal, healthy baby. So ventriculomegaly, again, is a soft marker, but does not mean that baby is abnormal. Again, a very common problem is the hypoplastic nasal bone. When a patient comes with a hypoplastic nasal bone, it is absent in 30 to 40% of trisomy 21, hypoplastic in 50 to 60% of trisomy 21. It's a strong marker for Down syndrome, but there could be other associations, syndromic or trisomy associations also with hypoplastic or absent nasal bone. So what we really need to do is a detailed anomaly scan and invasive testing for this patient. If cell-free DNA has been done, then we really don't need to do invasive testing. Choroid plexuses is another common problem that we face in our clinical practice. We need to tell our patient they're present in 30 to 50% of trisomy 18 patients and 3% of euploid patients. They will not cause any problem, no neurological deficit in the baby. But yes, we really don't even need to repeat a test to see the size of the choroid plexus, but some form of screening should have been done. Either it should have been a cell-free DNA or a quadruple test. Some form of screening for trisomy should have been done for the patient. Short femur, short humerus, again, we need to assess the other bones. We need to follow up for growth. We need to look for evolving skeletal dysplasia. So it's not just aneuploidy. We don't need to get scared. It can be a normal finding. But yes, we need to keep the patient, red flag that patient, keep her on high alert. If she's had some form of screening like a NIPT or even a quadruple which shows low risk, just follow up for skeletal dysplasia, follow up for evolving FGR, look for preeclampsia, follow up for oligohydramnios, and there is a possibility of unexplained intrauterine fetal demise. This needs to be counseled to the patient. But yes, there is no scare that should be put into the minds of the patient. ARSA is something that I wanted to mention, that is aberrant right subclavian artery. As an isolated marker, to be for Down syndrome, there's a lot of controversy. There's insufficient recommendation to recommend karyotyping in cases of isolated ARSA. But yes, like the previous case, with the multiple markers, we need to evaluate. And as an isolated marker, it does not increase the risk of Down syndrome. Single umbilical artery, a lot of times we get referrals for single umbilical artery. It is low risk for aneuploidy, about 1 to 2%. But yes, this baby could land up with SGA. It could land up with FGR, preterm birth. So therefore, we need to keep the baby on surveillance for fetal growth. So I think as far as the soft markers are concerned, to use them only for screening for Down syndrome, we need more studies. First trimester screening is the best that should be offered, and we need appropriate training and certification of competence. We have to have the competence to be able to pick them up adequately and to be able to prognosticate them. So I repeat that we need referral, we modify the a priori risk, and they are just markers for aneuploidy. Does not mean that the baby has Down syndrome. I think we all took the Hippocratic Oath, first to no harm. So whatever screening procedure we do should not merely be a test, but must be a comprehensive program. We need to be sure of what we counsel our patients whenever we marker on our ultrasound reports. Thank you so much.
Thank you, Dr. Reema. Could I request the chairpersons to please give their concluding remarks?
Hello.
Yeah,
Can I go ahead? Yeah.
Yeah.
Madam, it was wonderful presentation, and it is a day-to-day problem. And I really agree with you that at least most of the gynecologists, whenever they see a remark, such soft marker, and if they are not able to calculate any risk or something, at least try to make a fetal medicine referral first, if it is possible, so that patient is aware that there are some things. And you mentioned it so well. It was a very nice presentation. Thank you, madam.
Thank you so much for the invite. Thank you, Dr. Asha.
Thank you, ma'am. You know, there is a saying by Richard Bach, you teach best what you most need to learn. And I feel that I take topics that I need to learn a lot about. So thank you so much. Thank you so much.
So moving on to the next session, we have
Girija, just a second. Jayam ma'am, if you are there, you wish to say a few words? Ma'am, you are muted. Ma'am, you are muted.
The first thing is my pranams to Reema. You are at the lotus feet of Amma, and I am really feeling blessed to see Reema first. That is my first comment. And I think Pratima is also working with you. Am I right? Pratima Patil.
Yes, ma'am. Yes, ma'am.
That's a great thing. And I have been with Amma for the past 20 years.
Oh.
This thing. And this thing for this thing, people who accompany her have come and stayed at my house.
Wow, ma'am, you're so lucky.
The foreigners have come and stayed. And your lecture, the piecemeals which I heard, because tomorrow's preparation I'm going on, is excellent. And it is an eye-opener for every gynecologist. And they should have the courage to talk about these things very clearly, as you have said. I wait for the next lecture and put together, I'll come out with some suggestions. Anyway, thank you. Thank you, Asha. I'm
Thank
sitting.
you, ma'am.
Thank you, ma'am.
Arms to Reema.
Thank you, ma'am. So moving on to the next session, we have a talk by Dr. Rachita Ramamurthy. The session is on mid-trimester anomaly scan, gynecologist perspective. So firstly, I would like to introduce the chairpersons of this session. We have Dr. Sanjaya Sharma with us. She's the past president, Jhansi OB-GYN Society. Welcome, ma'am. We have Dr. Neeru Agarwal. She's a consultant laparoscopic gynecologist and infertility specialist at Om Multi-Speciality Hospital, Maharashtra. She's the secretary of Jalna OB-GYN Society. Welcome to today's session, ma'am. Next, we have with us Dr. Kanta Gupta. Madam is the president of Jammu OB-GYN Society. And finally, we have Dr. Girija with us. Madam is the associate professor of Hassan Institute of Medical Sciences. She has bagged the DK Tank and President's Rotating Trophy Award as a secretary of Hassan Society. She's also a trainer for various programs, and she's a member of the Board of Studies in Rajiv Gandhi University of Health Sciences. We welcome you, ma'am, to today's session. I would like you to please introduce the speaker for today's session, Dr. Rachita Ramamurthy.
Good evening, everyone. Thank you, ma'am, for the opportunity given. And I'm very happy to introduce Dr. Rachita Ramamurthy, who will be guiding us through the intricacies of second trimester anomaly scans. And she has a very short and sweet CV. She did her MBBS from Kempegoda Institute of Medical Sciences, Bangalore. And she's DNB radio diagnosis from Raghav's Diagnostic Research Center, Bangalore. She's a consultant at Srinivasa Ultrasound Scanning Center, Bangalore, and she has a special interest in fetal imaging and therapy. And she'll be emphasizing on the second trimester anomaly scan. Over to you, ma'am. Thank you so much.
May I add a few words? While Dr. Rachita is sharing, I would like to add that Dr. Rachita is the daughter of the famous Dr. B.S. Ramamurthy. And, you know, I didn't have the guts to call sir, so I called Rachita. Because I heard her a couple of times and she has imbibed what sir keeps teaching us, that is segmental, one by one. Point 1, point 2, and whenever she presents, I see sir in her. So welcome, Rachita, and I'm sure you're going to really do justice to the topic.
Thank you so much, Dr. Asha. Thank you, Dr. Sujaya, Dr. Girija, for those kind words of introduction. And you've set a very high benchmark for me now, so the pressure is on. But Dr. Reema did a wonderful job. She took us through the soft markers so well with such descriptive case examples. And now we have an idea of what to expect soft markers wise and how to deal with the risk calculation. I'll take you through the anomaly scan aspect of it, the structural study of the fetus in the second trimester. What should the clinicians, as obstetricians, as gynecologists, what should we expect in the report? What should we interpret from the report? And even before that, what should we ask for each particular patient? We need to be able to tailor make that anomaly scan, right? Because each patient is different. They may have different histories. They may have significant obstetric histories, previous family histories. So how do we incorporate all of those details into our anomaly scan request to get the best out of the anomaly scan in the mid-trimester? So let me just take you through the PPT. I'm sharing my screen. Okay. Just hide the drop down. So the mid-trimester anomaly scan is also known as the targeted imaging for fetal anomalies, or the TIFA scan, MTAS, TIFA scan. It goes by many different names, second trimester anomaly scan, or you can say genetic sonogram, some people refer to it as. All of these terms are the terms used for the study of the fetus in the mid-trimester. So this method is used to study the fetal anatomy in a systematic manner to detect any abnormalities. This entails the usage of standard ultrasound planes of section to display, describe, and follow up the various fetal anatomical structures, organs, and regions. So we know what a mid-trimester anomaly scan is, but we need to see why is it important, in whom should we do it, when should we do it, and of course, how do we do it. So in whom, we know that the mid-trimester anomaly scan is a standard screening procedure that we do for all pregnant ladies. So whether a woman belongs to the classic low risk group for structural abnormalities or the high risk group of structural abnormalities, whatever her previous risk is, we are going to do a detailed mid-trimester anomaly scan. So all fetuses undergoing an ultrasound examination must be considered abnormal to begin with, and every fetal structure is then studied in detail, and then only normality is ascertained. Hence, recognizing a fetus to be normal is the intense and active process that we go through in the mid-trimester anomaly scan. All fetuses must be considered high risk initially, and this is particularly because most abnormalities that we pick up in our day-to-day practices are incidental pickups with no previous pointers. Let's say, suppose a large lumbosacral myelomeningocele. It can come out of the blue in any pregnant lady. We need not have a pointer for a high risk in that lady. So anencephaly or corpus callosal agenesis, a cardiac anomaly, most of them are picked up in actually the low risk groups. So that is why it is very important to subject everybody to a detailed anomaly scan rather than a few, select few. The example I've quoted over here is cardiac defects, especially when you take the high risk category like mother with diabetes or maternal history of cardiac disease versus the low risk category with the general public with no previous history of cardiac problems. If you compare these two populations, out of 100 CHDs that we pick up, 20 only are of the high-risk population. Remaining 80 CHDs that we pick up are actually from the low-risk population. So that is why it's very important to do a detailed anomaly scan for everybody. So the high-risk situations, we must be also attuned to, because not just for everyone, if there is a high-risk in a particular lady, we must be more sensitized to look for those particular anomalies in a directed manner. So if the mother has a history of diabetes, if she's elderly, if she's on certain drugs, if there's consanguinity of the couple, if she has history of autoimmune disorders, then we are more attuned to look at things that could go wrong for each of these risk factors. The risk factors could be in her lab findings. There could be an irregularity in her first trimester screening, biochemical screening. She could have an AFP that is high. So we have to look at the spine more in detail. It could be a abnormal fundal height that you pick up clinically. So it makes sense if you mention that in the clinical request, so that the ultrasonologist knows that you have a doubt in this particular feature, and that we must look at the growth more in detail, or the amniotic fluid more in detail. When it comes to the obstetric history, there could be previous pregnancies with anomalies, cardiac defects, or any other syndromes. So those particular regions will be more in-depth dealt with. And this, again, we must mention in the request to the ultrasonologist, so that we are alerted to any family history, any obstetric history, any maternal high-risk factors, clinical or lab indicators, and also if we are sending it for a second opinion, if a scan elsewhere has shown an abnormal Leica volume, abnormal biometry, or a single umbilical artery, multiple gestations, all of those itself become risk factors for anomalies in the fetus. So by mentioning that in the request, we are going to get more yield from the anomaly scan. You're alerting the ultrasonologist that, look, this is where I have a doubt. Kindly focus more in this area. Specifically, like a volume, polyhydramnios, we know that there are 25% chances of anomalies in the fetus. Oligoamnios, it could be 33% chances of anomalies. So That itself should alert us that a more in-depth study is required. So we know in whom we should do it. It should be done in every single lady. And we also know that in certain high-risk categories, we need to put in more attention to certain areas. But when do we do it? And this is another very important question, because this is basically in your hands. It's in the obstetrician's hands, because you will be referring the patient to the ultrasonologist for this and this date. Get an anomaly scan during this week, or this date is what you write on the request slip. And that becomes very important, because the anomaly scan is best done. The golden period to do it is internationally 18 weeks to 24 weeks. But I will tell you that ideally, in our Indian situation, 20 to 22 weeks is the ideal time to do an mid-trimester anomaly scan, because the fetus is large enough. It's not too small. At 18 weeks, it's still a little small. And if the maternal habitus is thick, if it's a fatty lady, obese lady, if our machine is all centers may not have high-end machines. So if they have a low-end machine, the penetration will be low. So it might be very difficult to look at the same structures in a smaller fetus of 18 weeks rather than a slightly larger fetus of 22 weeks. So a 20 to 22 weeks fetus is a good size, a large enough fetus. There's good Leica volume around the fetus. So the fetus is free enough to move and show us all the structures in the different anatomical planes that we need. We need to study each organ in at least 2 to 3 different planes. So for that, the fetus needs to move around and show us all the structures. And also, most importantly, by 24 weeks, the ossification of the bones, be it the calvarium, the ribs, or the arm bones, the leg bones, the ossification is not very complete. So that means the ultrasound will be able to pass through the fetus, and there won't be any dense shadowing from other fetal parts to obstruct our view. So that is why this period is taken as the golden period. There have been a lot of studies to show that if anomaly scans are done too early, 18 weeks or earlier, we could maybe pick up only about 10 to 20% of anomalies. But if the anomaly scan is done 18 weeks or later, 82% of anomalies should be able to be picked up in the mid-trimester anomaly scan. That having been said, we are now in the era of not just a mid-trimester anomaly scan, we also have a first trimester anomaly scan. The NT scan that is traditionally done at 11 to 14 weeks doubles up as a first trimester anomaly scan. So if you are in the mind frame that, no, we can't wait till 22 weeks, we should, pick up anomalies fast, the major anomalies should actually be ruled out in the first trimester itself. So there should not be a hurry to do an early scan earlier than 18 weeks in the mid-trimester, because we are at a risk of missing out on few anomalies if we do the scan too early. And of course, if it is later than 24, 25 weeks, later than the third trimester, then our anomaly scan will be very limited. The bigger the fetus, more difficult will it be for it to turn. We won't be able to get parts in the right view to look at them. There'll be a lot of bony shadowing from the calvarium, from the ribs, etc., to obscure ultrasound penetration. So our image quality will not be very great. So ideally, this is the period. If you want to do a scan earlier than 20 weeks, then we must keep in mind that it is too early to look at the midline brain structures, specifically the corpus callosum and the vermis develop only by around 20-21 weeks completely. They complete development by around 20-21 weeks. So we need to wait for that period of time to pass to be able to study those structures. So if we do a scan at 18 weeks, there's always a small risk that we are missing out on corpus callosal or vermian abnormalities. So that one thing that we must keep in mind. And if we do the scan too late, if it crosses beyond 23 weeks, our markers may become a little difficult to assess. Like Dr. Reema said, the nuchal fold thickness up to 6 millimeters is considered as normal. But we must remember that as the fetus grows, the soft tissues are also growing along with it. So the nape of the neck skin is also becoming thicker and thicker. So invariably, beyond 23 weeks, the nuchal fold thickness will be 6 millimeters or higher. Most half or more than half the fetuses will show a 6 millimeters or higher NFT, and we're going to be giving false positive thick NFTs. So whenever we see a report of 23 weeks or 24 weeks fetus with a thick NFT, please take it with a pinch of salt. That could be very normal because the soft tissues have grown with the fetus. So keeping these two in mind, And of course, the 24 weeks deadline that we have in India for the MTP Act, keeping all of this in mind, 20 to 22 weeks is the ideal time to send for an anomaly scan for any lady. So if at all you have a very pressing need to do an early scan at 18 weeks, always please suggest a repeat anomaly scan around 22 to 23 weeks so that we get to see the structures much more clearer, the corpus callosum, the veins of the heart, the pulmonary veins, the smaller sulcal details of the brain, all of those will be much better seen at 22, 23 weeks. So that is the ideal time. So when we write out, as clinicians, when you write out a request for an anomaly scan, please calculate the weeks from her earliest dating scan, from her LMP, menstrual age, calculate if both of those are correlating, then calculate when she will be 20 to 22 weeks, and then suggest the scan during that period. That will be the best thing to get the scan done at the right time. What ultrasound equipment should be used? This, of course, a good ultrasound machine should have all of these parameters, which I won't go through because this is more important for the imaging side of things, not for the clinical side. But we must know that when we are sending for an anomaly scan, they should be equipped with a decent level of ultrasound equipment to be able to see the structures well. Now, coming to the important part of the topic, how do we do the anomaly scan? What are all the structures we go through? There are standard guidelines. It's not that each ultrasonologist does whatever he or she feels like in a mid-trimester anomaly scan. There are multiple guidelines, international guidelines, for example, the ISWAG guidelines, the American guidelines, our own Indian guidelines, but for most practical purposes, the ISWAG guidelines is what we follow. Most people follow the ISWAG guidelines because they're very clear, they're very, very clean cut, and it's easy to follow them. And I'll be taking you through the sections that are required as per the ISWAG guidelines. So they even have a full checklist. The guidelines come with a full checklist, and this is the minimum that we need to see in all of these fetuses in the mid-trimester to be sure that we've done a complete study. And before we start off the scan, the first step in the mid-trimester anomaly scan is the history. And that is, again, as I said, very important. We must make a note of the maternal obstetric history, the medical history, if the mother's on any other medication, any other autoimmune disorders, etc., that could affect the fetus. A family history. Is there a consanguinity in this couple? Is there a history of cleft lip in the family? Is there a history of clubfoot in the family, cardiac disease in the family, etc.? We must make a note of that. Investigations, please look at what are the other reports that the lady carries. The lady could be following up with you throughout the pregnancy, then we know what are the reports that she has. But if it's a fresh case that has come to you, please look at the previous scan reports and lab reports to see if there's any abnormality mentioned in any of those reports, which could again affect the anomaly scan, and we must, look at those structural details with more focus. I've just put up two examples of histories of, I've just generated dummy reports just today to show you how important the history could be in the mid-trimester anomaly scan. In the first report on the left-hand side, these are the pointers that we have for this lady. It's a 30-year-old lady. Third degree consanguinity. So that's one alert already. That means there is a chance of genetic abnormalities that we could expect. And also she has a previous obstetric history where in her first pregnancy, she had a termination of pregnancy at 20 weeks for a congenital diaphragmatic hernia. And unfortunately, there was no molecular testing for that done for that fetus. They went directly for a termination. She's come now in her second pregnancy. The second pregnancy is the present pregnancy, but again, she also has history of diabetes mellitus, and she's on insulin, and also she's taking AKT4, she's taking anti-tubercular medication. So we need to know this because diabetes, we need to see that the fetal growth is normal. We need to see if there are any abnormalities in the heart, the spine, the All the vectorial associations that we generally expect is what we will concentrate on. And also, we need to look at the teratogenic effects of these drugs. We're going to keep that in mind. And another thing is this lady is Rh negative. She's O negative. Her husband is A positive. So there is a chance of Rh isoimmunization. Anti-D was taken after the previous TOP, but that still tells us that we must monitor the MCA-PSV in this current pregnancy, and the rest of the study will follow. Coming to another example of history and how it will affect the course of our anomaly scan is this report. And this is a lady that I saw today, and she had a very complex history because her first pregnancy, she had a 2-year-old with severe global developmental delay, epileptic encephalopathy, for which they'd done a karyotype, and the karyotype was normal. But they did do a whole exome sequencing, and the whole exome sequencing revealed 2 gene mutations, and one of the gene mutations was autosomal dominant for developmental and epileptic encephalopathy 7. Mutational analysis for the couple was also done, and both parents luckily were not carriers for this pathogenic gene. The husband was a carrier for the second gene, which was autosomal dominant for myopia. So we know that this couple already has a significant genetic history, and they're coming for a mid-trimester anomaly scan. So we are going to concentrate on this aspect of it. Second pregnancy is a present pregnancy. It's an IVF conception. And this again is important to note. We have to take a history of whether it is a spontaneous conception or an IVF conception, because the age of the fetus will be very, very surely ascertained if it is a IVF pregnancy. Embryo transfer was done on such a date. So we know the age of the fetuses exactly. And we also take her menstrual history, and both of these were correlating. And she also comes with a combined test, first trimester combined screening, where 2 different risk figures are given for fetus A and fetus B, which is correct because she's carrying a dichorionic, diamniotic twin gestation right now. We know that each fetus will behave as though it is an independent singleton fetus. So we need independent risk figures for each of these fetus A and fetus B. And she is carrying a report with these 2. So given all of our history over here, I know now that in this scan, I know that it is a dichorionic diamniotic twin pair. So I need to see the growth of each fetus, which I've done here. I need to do a detailed structural evaluation, particularly concentrating on the intracranium or the CNS structures of both fetuses, given the history of the index child. And also, even though the couple is not a carrier for this gene, I will still suggest that this couple go and speak to a geneticist to be sure that they do not require an invasive testing in this current pregnancy, or they might even opt for an invasive testing in the current pregnancy to rule out this particular pathogenic gene. And coming to the risk assessment, I know that I have my a priori risk from the combined test. So my starting off point now will be these risk figures, and I will further try to bring them down or increase the risk based on the findings in this report. So that is how important all of this history is before we move on to the rest of the study. Coming to the next step in the study, it's a survey of the entire fetus. We need to do a sweep from the fundus to the base of the uterus, and for that, in doing so, we get to know the number of fetuses. The cardiac activity, is it present or absent? Fetal movements, we'll get to know if it is an active fetus. The position and the lie of the fetus is best seen on a survey, and based on the position and the lie of the fetus, we determine the fetal side and the situs. And that is the first step we need to do to see which side is the right side of the fetus deep, or is the right side of the fetus superficial. So the rest of our structures are studied based on these sides. And then the step 3 is to do the biometry of the fetus. And the biometry in the mid-trimester, we know we take the head circumference, the biparietal diameter, the abdominal circumference, and the femur length. I won't be going through how exactly to do each of these parameters, because that's the imaging a person's responsibility. And we just need to know that all of these 4 parameters should be taken on standard planes of section. And these are the standard planes of section that I'm showing you. And if these are done in the standard planes, we know that these measurements are reliable. Otherwise, there can be a lot of things that can go wrong, even in these 4 basic measurements. And what is important for the clinicians to interpret from the report is not the absolute values of each of these measurements, but the percentiles that they come along with. Each of our reports will carry such a list of measurements where we tell you the biparietal diameter, female length, humerus length, head circumference, abdominal circumference, not just the absolute values, but also the percentiles, PCTS percentiles. And we know that for any of these parameters, 5 to 95 is normal. So if all of these parameters is falling between 5 to 95 percentile, we're happy, we know it's in the normal range. If any of these goes below 5, it's abnormally small. If any crosses above 95, it's abnormally big. And then we also need to look at the ultrasound average age. Is it corresponding to the age assigned to the fetus as per the LMP or the dating scan? That is the exercise we first do before to see which point we start off from. Is it menstrual age we're taking, or are we assigning as per dating scan? If there's a difference, we take the dating scan. So is the ultrasound size correlating with age is what we look at. And more importantly, the fetal weight. The fetal weight should normally be between 10 to 90 percentile for that gestational age. And over here, all of them are coming in the normal percentiles. And that should be represented by a chart like this. Please make sure that all of your anomaly scan reports that you're getting back, or beyond that, a growth scan report should have normograms like this, which is a graphical representation telling you that all of the measurements are in the normal range for gestational age. That was a normal example I showed you where all the biometric parameters are normal. Let's look at a case example over here. I've shown you a bunch of images where by looking at the biometry alone, even before I look at the images, by looking at the biometry alone, can any of you tell me where the problem is over here? We know that the problem is in the long bones. Absolutely. Just by a single glance, just by looking at these percentiles, I know the HC, BPD, AC are in the normal range, but all the long bones are falling much below the 5th centile. They're all at least 4 to 6 weeks lesser than what we expect for that gestational age. So we know that this is a skeletal problem. And then when we look at the other pictures, and the report, we know that the long bones are extremely short, and also there are multiple fractures and angulations in the long bones, multiple fractures everywhere. The thorax is narrow. That's a narrow thorax with, again, multiple fractures in the ribs. That's a 3D rendering of multiple rib fractures. And you can see the intracranium over here. The shape of the cranium is all right, but there is absolutely no reverberation or no shadow at all from the near calvarium, which tells us that the ossification also is a problem here. It is a hypomineralized skull. So putting all of this together, we know that it is a case of osteogenesis imperfecta. So that is how important the percentiles are. More than this column of weeks, this column of percentiles is important. So if y'all are used to seeing reports where there are a list of measurements and then a list of weeks, please start asking your ultrasonologist or the imaging specialist to give you this list of percentiles as well, because that is extremely, extremely important to interpret reports. And once we're done with the biometry, we go to the structural study, targeted study from a head to toe sort of examination of the fetus. And these are all the things that we cover. And there are standard planes of reference as I showed you in the ISWOG list. And I'll quickly take you through them. I'll show you what's normal and 1 or 2 abnormal case examples and what to do about it. In the fetal cranium, the standard planes are axial planes, and ideally, again, your anomaly scan reports that you receive back should have a picture like this, showing you an axial section of the brain in the transventricular plane and the transcerebral plane to show you that there's normalities here. They can take measurements on these images of the transventricular diameter, nuchal fold thickness, transcerebellar diameter is taken on these sections, and that is what is required for a normal study. And then if there are any abnormalities found in these axial planes, say suppose there is a small CSP, then we move on to the mid-sagittal section, and on a mid-sagittal section, we try and see the corpus callosum in detail. Like in this case example, the corpus callosum is not complete, the posterior body is is very thin, splenum is not seen at all, and the length of the corpus callosum is lesser than 5th centile for 23 weeks of gestational age. So this was a case of partial agenesis of corpus callosum. So once you see a case, example of a partial agenesis of corpus callosum, what next? So as clinicians, you need to know that partial agenesis of corpus callosum is not a good thing. It's a abnormality which has quite a lot of developmental deficits that could occur in the child. So that is one thing that we need to counsel the couple about, put them across to a neurodevelopmental specialist to get even more details. And also we need to know that this is a structural abnormality that has a multifactorial etiogenesis. It could be chromosomal etiology, single gene disorders, infection, etc. So looking at all the other findings in the scan, we should be able to suggest further tests like invasive testing to rule out chromosomal anomalies by chromosomal microarray, whole exome sequencing for single gene disorders, and also to rule out infection, we can do a torch serology either on the maternal blood or directly a PCR study on the amniotic fluid. So all of that, ideally, the imaging specialist should be, if it is a fetal medicine specialist, they should be putting all of those points down in the report so as to make the life of the clinician that much easier. So whenever we see an abnormality like this in our center, we put the anomaly, describe it in the impression, then also suggest what the next steps are. And we also, of course, call the clinical or referring doctor to discuss the same with them so that they also know what they need to do next for the patient. So the same thing, you could have an complete agenesis of corpus callosum with an interhemispheric cyst, and that may also require a fetal MRI to delineate the structures better. And we can see the progression of this at 18 weeks, 31 weeks, and on a late fetal MRI, how the different picture keeps evolving. So it's not just picking up the anomaly at 20 weeks. We give always the choice to the couple, whether they, with all the testing that is possible and with the counseling with the neurodevelopment specialist, it is up to them whether they want to continue or not. And if they continue, we have to look at follow-up studies for further developments that is expected in the brain. If one anomaly is found, expect other anomalies. Look at sulcation, look at other signs of infection that may crop up later. So follow-up studies become very, very important. So prognostication, I've already told you, won't go in detail. Other common anomalies that we can come up in the mid-trimester are a Dandy-Walker malformation with a huge posterior cranial fossa cyst, such as this, which can also give rise to ventriculomegaly. So what is the prognosis for that? What is the testing that is required? And of course, we must know that not all posterior cranial fossa cysts equate to Dandy-Walker malformation. It could be just an open fourth ventricle, and which may be a Blake's pouch cyst, which is very good prognosis. So whenever we see a fourth ventricle, posterior cranial fossa cyst and an open fourth ventricle, make sure that the report tells us what is happening with the vermis. Is the vermis normal or abnormal? If the vermis is normal, prognosis is good. If the vermis is flattened and deformed, then prognosis is bad. So that is what we need to expect in the anomaly scan. So coming to the fetal face next, the face, we need to look at the orbits, the nose, and that's the tip of the nose, 2 nostrils, and the upper lip is what is basic in the ISWA guidelines. We also need to look at the palate to see that there's no cleft in the palate. We do a axial section or a coronal section for these two, and we also do a mid-sagittal section for the profile view of the face to look at that there is no hypoplastic or non-ossified nasal bone, and also to see that there is no micrognathia or retrognathia. These are the basic views that we expect in the report. And again, when we look at the images attached to the report, it is a good thing if the radiologist or the imaging specialist are giving you a picture of the midline of the face, because that will give you the details of the brain as well, and it will give you details of the face. And we know that the imaging specialist has taken care to look at that. And the abnormality that we could pick up here most commonly is an example like this, which is a cleft lip and a cleft palate. Here you see a break in that line of the vermilion border of the upper lip. That is a paramedian cleft, and that cleft extends into the palate here. That's the alveolar arch, and that cleft is extending into the palate. And if you do a 3D rendering, you also know that the secondary palate is involved. So the anomaly scan, it's not enough to say cleft lip and leave it alone. We need to see that the imaging specialist has taken extra pains to look at the palate inside, to do a 3D rendering or to do a direct examination of the secondary palate to describe what is the extent of the cleft. And only if we know the extent of the cleft is when the reconstructive surgeons can better prognosticate and talk to this couple regarding the management. And of course, we should know that whether it is cleft lip alone or cleft lip and palate, again, it requires an invasive testing to rule out chromosomal abnormalities. Rule of thumb, any anomaly that is picked up will require a basic of chromosomal microarray at least. And based on the pattern of anomalies that we find, we could also be thinking of a single gene disorder for which we may need a whole exome sequencing as well. But a minimum of chromosomal microarray is a must if any anomaly, isolated or not, is picked up in the mid-trimester anomaly scan. And I'm talking about abnormalities, anomalies, not for soft markers of aneuploidy. For anomalies, definitely CMA. Coming to the next, we go to the chest, and in the chest, we study the heart and the lungs on either side. That's a normal 4-chamber view of the heart. You have lungs symmetric on either side of the heart, and the heart itself should be studied on 4 views at least: the 4-chamber view, left ventricular outflow tract, right ventricular outflow tract, and the 3-vessel view. And if all of these views are normal, in a basic study, it is described as normal. The lungs are easy if there are symmetric on either side of the heart. There's no echogenic foci, there's no hyperechoic areas or cystic foci, there's no shift of the mediastinum, then we know that the lungs on either side are normal. So these are the 4 other views that I told you for a basic study of the heart. And I'll show you a few abnormalities now. This is a 20 weeks fetus that comes with a gross mediastinal shift. And you see that one lung is extremely hyperechoic, and there are also multiple hypoechoic cystic foci all around. And this is a classic, what we call as a congenital pulmonary airway malformation. The picture is classic of that. And then you calculate your 3 indices. You take the longest 3 measurements on the 3 orthogonal planes, and then not just describing it as a CPAM, we also need to prognosticate how much problem is this lung pathology causing to the fetus. And that is given by a CVR, CPAM volume ratio, where the volume of this lesion is calculated, divided by the head circumference. And if it crosses 1.6, then it is poor prognosis. If the ratio is less than 1.6, it is decent prognosis. And then not just this, we also need to look at blood supply. Is this lesion getting blood supply from the aorta directly? If it is getting blood supply, then it's not a simple CPAM. It becomes a bronchopulmonary sequestration. It's a hybrid lesion, a CPAM with a sequestration. And that will again change the prognosis and investigations that we may need to do. Most of these are benign findings. They usually regress on their own. Whenever we see a lung pathology, we do suggest for repeat scans. This lady came back to us at 24 weeks, and what was so large and abnormal looking started regressing by 24 weeks. You can see that the heart that was pushed completely to the right comes a little bit more into the midline at 24 weeks. And by 30 weeks, the heart is absolutely in the normal position. And such a grossly abnormal looking lung has almost become normal looking. So we must know that these CPAMs, bronchopulmonary sequestrations, are known to regress on their own. So let's not press the panic button at the 20-week scan itself. Let's give this fetus a little bit of time, rescan at 24 weeks. By 24 weeks, we're a little reassured that it is regressing. And by 30 weeks, we're very happy that the prognosis is good in this fetus. So that becomes important to look at the CVR ratio and also send the lady back for follow-ups. And coming to cardiac anomalies, the cardiac anomalies, there are millions of types that can happen. This is a classic example of tetralogy of Fallot. So once a tetralogy of Fallot is picked up, it's not just the diagnosis. The imaging specialist should also tell you how narrow the pulmonary artery is. Are there any other findings with regards to the lungs, with regards to the rest of the fetus to prognosticate and also investigate and put them across to a cardiac specialist for further treatment? Coming to the abdomen, we look at the kidneys, we look at the stomach, the liver, bowel, and the urinary bladder. So these are the main structures that we look at. And another important thing to look at is the gallbladder under the liver. When we do a sweep, we do look at the gallbladder under the liver. So these structures are normal, and if they're mentioned in the report, that's fine enough. All the anomaly scan reports need not measure the pelvic diameter of the kidneys. If it is less than 4 millimeter pelvic dilatation, it's absolutely normal, and that need not even be mentioned in the report. But if there is a pelvic ectasia beyond 4 millimeters, that definitely needs to be measured, and we need to look at whether it is only the pelvis that is dilated or also the calyces that are dilated. If the calyces are also dilated, then we know that there is a chance that it could be an obstructive pathology like a PUJ obstruction in this case. And again, this fetus will need investigation. It will need monitoring, follow-up every 4 weeks to see how much this is progressing. What are the changes in the parenchyma of these kidneys? Are there back pressure changes? Are there cystic dysplastic changes? What is happening to the LICA volume, the bladder filling, etc., to be able to prognosticate? And again, please put them across to a urologist. And just show you a case example of another problem that we could encounter in the mid-trimester, ecogenic kidneys. As Dr. Reema said, ecogenic kidneys are a marker for aneuploidy, but there are also markers for autosomal recessive polycystic kidney disease, or even autosomal dominant polycystic kidneys. These are kidneys which are very large and ecogenic, and at a single shot, you know that the bladder is not filling at all. The LICA around the fetus is almost nil. So this is a clear-cut case of autosomal recessive PKD, where the kidneys have shut down. There's no function. That's why there's no bladder filling, and there's no LICA. And you know that this is a lethal condition. But in another example, like in this case, where the kidneys are normal in size, but you have ecogenic parenchyma and the LICA volume is normal, then what do we do next? The bladder is filling normally, LICA is normal. This we'll have to further investigate. We'll have to rule out aneuploidy. We'll have to rule out autosomal dominant polycystic kidney disease, and for which she'll need an invasive testing. She went through an amniocentesis. Sorry, Dr. Asha, I'm almost done, 5 minutes. So we do a FISH and a karyotype. FISH and karyotype both came out normal in this lady, but she also luckily went ahead with a whole exome sequencing, and the whole exome sequencing picked up a PKD1 gene mutation, which is pathogenic, autosomal dominant for autosomal dominant polycystic kidney disease. So that is how we, the most 90% of these cases may turn out to be normal, but to pick up those 1-2 abnormalities, we'll have to go through all the investigations to pick those 1 or 2 up. And whenever we see any renal pathology in the fetus, we always check the mother's and the father's kidneys to see especially if there's any signs of autosomal dominant polycystic kidneys. Coming lastly to the spine and the limbs, the spine is studied in 3 orthogonal planes, axial, sagittal, and coronal. And if it's normal, well and good. But if we may pick up a most common abnormality, which is an open neural tube defect here, and that can give rise to sequelae. And when there is an open neural tube defect reported, the things that you must be able to get from the report is the lesion level. Is it lumbosacral? Is it sacral alone? Is it thoracic alone? And what is the topmost level of vertebra that is affected? In this case, it is a lesion level of L2. So that is the topmost level of vertebra that is affected. Higher that level, worse is the prognosis, because worse are the neuromuscular sequelae and more difficult it is to repair for the neurosurgeons. And then apart from the local pathology, what else is happening in the fetus. Is there an Chiari2 malformation? Anytime an open defect is seen in the spine, Chiari2 malformation is expected in the brain. So if this couple is opting to continue, this will again require follow-up every 4 or 5 weeks to see whether there is hydrocephalus developing in the brain, and also to see neuromuscular sequelae in the feet. Are there any club feet or paucity of soft tissue developing in the legs? All of that should be expected from the report when you read it. Coming to the limbs, all 4 limbs should be documented in all 3 segments. That is the proximal, mid, and distal segment of all 3 limbs should be documented and put in the report. Counting of fingers is actually not part of any guidelines, and we are not really supposed to be counting right hand 5, left hand 5, right foot 5 toes, left foot 5. And believe me, it's extremely hard to count the number of toes in a 20 weeks fetus. We just need to see that the digits are present, and this is how we document the limbs and see that the lie and the movements of the limbs are good. And if there are any positional abnormalities, the most common one that we come across is a congenital talipes equinovarus. This was a bilateral congenital talipes equinovarus. And even if it is isolated, we know that we need to do a chromosomal microarray and put this couple across to a pediatric orthopedician for further management. Lastly, the report should mention the placental location, the quality of the placenta, the liquor and cervix, and also the uterine wall. Any fibroids or any abnormalities seen in the adnexa should also be mentioned in the report. Cervical length should be mentioned in the report, and internal os, either closed or open, should be mentioned in the report. And that is what we need to check. The cord insertion, again, we need to look at the fetal side of the cord insertion and the placental side of cord insertion. And we need to see that there are 2 umbilical arteries and 1 vein, which is a normal 3-vessel cord. And if there's any abnormality there, like an omphaloceal or a gastroschisis, that again will require further attention and treatment. So markers of aneuploidy in any mid-trimester anomaly scan, we should also be including all the soft markers that Dr. Reema took us through. So I won't take you through the soft markers. We've already gone through that, but our report in the end should mention those soft markers like this. The list of soft markers that we have seen, and are there score 0 or score 1 for us to do the risk calculation. So points to note, this I feel is the take-home points from my lecture. As clinicians, these are the points that we must note in each of the reports. Read the body of the report as well as the impression, because sometimes some findings may be put only in the body and not in the impression. Check the gestational age assigned for the fetus, the starting off point. Are they taking the menstrual age or a dating scan report? And see whether the growth is corresponding, for which we need look at the centiles of the measurements. Or please always remember to look at the images attached. When you look at the images attached, you yourself will be so reassured that yes, a good detailed study has been done. Nice, sparkling, good images have been given, not some small stamp-sized dark images where nothing is seen. Then you yourself won't have confidence in believing in such a report, right? Good, nice, large images of at least the main structures should be attached with the report. Risk assessment should be mentioned in the report for Down syndrome. If any abnormality is given, what are the next steps that have been suggested? Always please check the report if there are any reviews or rescans that are advised. In an anomaly scan, sometimes the fetus may not pose. It may not pose to look at the spine. So we may have added an addendum saying that we've checked 3-4 times today, but it didn't pose to look at the spine. Please send her back 1 or 2 days later to look at the spine. So that it is now the onus of the lady to come back to us to look at the spine, and also if any rescans have been suggested. Let's say, suppose an Rh negative mother, MCA Doppler surveillance will be required. If previous history of diaphragmatic hernia, repeat scans at 26 weeks, 32 weeks for late onset diaphragmatic hernia may be always recommended. So please make a note of that and advise the lady accordingly. We must remember that not all anomalies can be detected by ultrasound, and that too, of all the anomalies picked up on ultrasound, not all of them can be detected by 20 weeks itself. Evolving anomalies are a very large percentage of this. Some of anomalies can appear late, and even if we pick up an anomaly at 20 weeks, it may evolve. So the prognosis may change. Some anomalies may become better, like the congenital pulmonary airway malformation. Some may worsen, like a coarctation of aorta or a diaphragmatic hernia can worsen. look at the pattern of anomalies. Is it isolated? Is it non-isolated? If there's a pattern that is recognized, the associated anomalies should dictate the prognosis and also the invasive testing required. And depending on the anomaly, is it an anomaly that is lethal or non-lethal? Is it going to cause an emergency postnatally? Because certain anomalies will require tertiary care, like a congenital diaphragmatic hernia. That fetus should be delivered at a tertiary care center because it will need immediate NICU care. So to differentiate that, we must be able to know which anomaly requires what sort of treatment. A congenital pulmonary airway malformation may not require any immediate treatment. A pelvic ectasia may not require any immediate treatment. That is not an emergency, can be delivered at a regular, a primary healthcare center even. So counseling, monitoring, further workup, multidisciplinary care, all of that should be mentioned in the report. And if they're not mentioned in the report, please talk to the imaging specialist to get a better idea so that the couple is counseled accordingly. Thank you very, very much for a very patient listening. I'll leave you off with this. So picking up abnormalities, recognizing patterns, counseling, and the legal issues is very important, which should be documented in the report. Make sure all of it is documented in the imaging report, and also that you document it in your clinical notes. Whenever you counsel a couple, say that you have discussed with the couple, suggested a consultation with a cardiac specialist. Make sure it is in writing so that in 1 year later or 2 years later, there should be no issues that can arise later. And then once an abnormality is identified, whether it's lethal or non-lethal, what type of test is required on the amniocentesis. It's not just enough to know that you need to invasively test this fetus. Invasive testing, amniocentesis, but for what? Is it for chromosomal microarray alone, or is a whole exome sequencing? Get a geneticist involved. Repeat scans to follow up or trend the anomaly that you find. Indication for 3D, Doppler, or MRI may be required for certain anomalies. So discuss that with the fetal medicine specialist. A neonatal or an autopsy follow-up, if they opt for a termination, please do an autopsy, a detailed genetic study postnatally to look at the final diagnosis. And all of this will affect counseling for future pregnancies. And that's how important it is to do a complete study. Thank you very, very much for a very patient listening.
Thank you so much, Dr. Rachita. You know, I had allotted 20 minutes.
I know I've taken 36 or more, I think.
But I didn't feel like interrupting you, because the thing is, what we are going to take later is just basically to see what we have retained out of what you and Dr. Reema have already said. So I didn't want to interrupt this, and believe me, you were really good. So over to the chairpersons for comments, and then Jayam ma'am and Bimal sir, and then we proceed to the panel. Jayam ma'am?
You're on mute, Dr. Jayam. Yes.
I literally felt I'm hearing Ramamurthy. I have heard him while we were traveling in train.
Oh, wow.
Yeah, he used to take train lectures. That's how we this thing, we'll sit 10, 12 people and he will take lecture. Anytime we ask, he will take lectures. From here, this thing, in the present day point of view, with our toxemias going up, with the early markers coming up with the fibronectin and split PGF ratio, how much, if that history is available to you, you will modify your mid-trimester scan findings?
Yes, most often a double marker test is done for most women, but if they've added a placental growth factor, we always take in that also. We make sure we see that risk that is given, preeclampsia risk that has been assigned to the lady. And in the mid-trimester anomaly scan, we make extra care to see the growth of the fetus. And if she is on high risk, we don't expect growth abnormalities to be seen as early as in the mid-trimester. We need to put them for monitoring in the third trimester. That is when it becomes important.
The second one, I appreciate you have talked about request for the percentile report.
Yes.
Nowadays, the fetal medicine experts are not sending it. So I called a couple of people and asked them for the centile report. How early you think now the centile report can be started? Earlier, it used to be Hadlock and only by 20 weeks. Do you
Yeah,
think
Hadlock measurements we get for any week of gestation, ma'am. Even earlier than 20 weeks, we get the percentiles. It's a simple step. All they need to do is put on the chart worksheet on the machine, and automatically those percentiles come up if the
Come up.
gestational age is assigned. So
Because in my centile report,
Rachita.
I start get from when I start doing in my machine, 8 weeks onwards I get it.
yes.
Nowadays, because NT scan has to be certified by a fetal medicine expert, we are not doing double time. But they say we will get a centile report only from 20 weeks.
Not at all. 18 weeks, 16 weeks, at any gestational age, centiles have to be given.
Once we give the earlier findings, they can load that finding in their film.
Yes.
Centile. Am I
Yes,
right?
that's another thing. If we are seeing a lady at 24 weeks and she's had 2 previous studies done, we need to manually enter all those values in our machine to get the trend of growth. Then that's most important to see the trend.
I'm very
Possible.
happy. Asha gave me a chance to drill my fetal medicine experts. Tell them, kindly load these findings and give me a centile report. Thank you. Thank you. Nice.
Thank you, Dr. Rachita. That was so good. But you need to tell about the Dopplers, which are not strictly a part of the
Anomaly scan.
anomaly scan, but you need those reports, right?
For the uterine artery Doppler, you're asking, ma'am?
At least uterine artery Doppler, umbilical artery, you should have that record. That is what I feel.
No, actually, as per guidelines, if the growth is normal, we are not meant to do any fetal Dopplers.
Uterine artery?
No, umbilical artery and MCA Doppler specifically, we don't need to do at all because it will give us false abnormalities. If the growth is normal at 20 weeks, we know for sure the Doppler is normal.
And what about uterine?
Uterine arteries, again, it's controversial. Best time to screen is in the 3rd month in the NT scan. Our NT scan reports, 100% of them carry the uterine artery Dopplers. Mid-trimester anomaly scan, if the first semester screening has not been done, or if it is a high-risk lady, we ourselves do the uterine arteries, or we go by the referring doctor's choice. Some people ask for it, some people don't ask for it. So that's still not a standard guideline as such in the mid-trimester to include in all reports, but there's no harm. Screening Doppler definitely can be included. Fetal Dopplers, there's no role actually in the mid-trimester anomaly scan.
Agreed. So, chairpersons, would you like to add something before we end this session? Thank you, Jem, ma'am. Thank you so much.
Thank
you. Chairpersons, would you like to say something? Dr. Smita, Dr. Girija?
Yeah.
It was an excellent presentation, ma'am. You took us through the 2nd trimester anomaly scan so well. And it was excellent. That's all I can say.
It was excellent tour. It was very nice presentation, but madam, we still insist on having a uterine artery Doppler.
Okay.
In NT scan, we do insist on having it. And maybe after that, not fetal Dopplers, but uterine artery scan Doppler, sometime any continuity of pre-eclampsia study, it is helpful.
Yes. No, we do it on our own if we feel first trimester screening was not done, and if she's not on ecosprin, she's not on any prophylaxis, we definitely do it. But we leave it to each obstetrician's purview over here, ma'am.
Okay. Thank you so much, Rachita.
Thank you so much. Thank you, everyone.
Thank you, Dr. Smita, Dr. Girija, ma'am. And now I would proceed with the panel. I request Piyush, please give me sharing rights. Dr. Reema, you are still there. Would you like to say something? Piyush, I do not have sharing rights.
I just made you the co-host. Can you please recheck again?
Okay. Okay. My slides are visible?
Yes, ma'am.
Yeah. Okay. So, welcome to this panel. And it's nothing new. It's just what we have already learned. And we are going to take it like bullets literally like bullets. That's me. And Suja would have introduced me, but I hope you all know me by now. So I'll be going for Chairperson, Food, Drug and Medico-Surgical Equipment Committee. I request all of you to nominate me from your societies. And these are my panelists and my experts. I will be introducing them in detail. Dr. Bharati Rajshekhar from Hassan, the president of Kasoga. Dr. Swati Kumari, who's the vice president of SFM Chhattisgarh. She's a consultant of fetal medicine in Raipur. We have Dr. Aditi Bansal. She is a professor and fetal medicine consultant at SMS Medical College, Jaipur, and she is the secretary of Jaipur Society. Dr. Binod Agarwal, sir, who's the president of Jamshedpur Society. He's a consultant, lab surgeon, and IVF specialist. We have Dr. Sarita Kumari, who is the secretary of Jamshedpur Society, and she has an interest in lab surgery. We have Dr. Vidya Chaudhary. She is from Jhansi. She is the secretary of Jhansi Society, and she has many awards and achievements. We have Dr. Pallavi Agarwal. She's from Raipur, a fetal medicine specialist and a radiologist. We have Dr. Harshad Ruprela, the president of SFM Chhattisgarh, and a radiologist with his areas of interest as fetal Doppler, fetal echo, vascular limb Dopplers, and endoanal ultrasound. We have Dr. Manisha Kiran. She is also a fetal medicine specialist and a director consultant life care fetal medicine Bhimavaram. Welcome, ma'am. Her interests are fetal therapy. We have Dr. Kirti Somu from Hyderabad. She is a fellow of Academy of General Education from Manipal Academy, Fellowship in Fetal Medicine at Resolution Fetal Medical Center under Dr. Chinmay Ratha. She has 2 index journal presentations. And these are the soft markers and their follow-ups. These have already been shown by Dr. Reema. So these are the 8 different soft markers, and the images that I have taken are from the ultrasonography soft markers of aneuploidy in 2nd trimester. So the choroid plexus, the echogenic focus. Now we go to the first case. I have not assigned anyone any case. I request all the panelists kindly please put on your videos so I know who's here. And I request all the experts also to put on their videos. Thank you so much for being here. So there's a 23-year-old Gravida 1. Her mid-trimester scan is done and she is told that she has bilateral choroid plexus cyst. There is no other finding, no other positive finding on the mid-trimester scan. So what will be your course of action? She has an isolated anomaly. So what will be your course of action?
Ma'am, may I come in?
Yes, ma'am.
Ma'am, if there is an isolated finding, then we have not to worry because the associated risk of trisomy 18 and 21 is very low if other markers are absent. So we should have to only do the detailed ultrasound examination for the presence of other markers of trisomy 18 and 21. And in the absence of other markers, there is no need of invasive testing in this situation.
Okay, so do you think that the a priori risk is important? Means
yes, ma'am. If her previous report of anti-NB scan and double marker is normal, then there is then it also says that there is a very less chance of other associated anomalies.
Okay.
Or history and is also very important.
Okay. So what will be what are you going to counsel this patient? See, the parents are absolutely in a flutter. Dimag mein kuch ho gaya hai, abortion kar do. So how are you going to counsel this patient?
Ma'am,
like, yeah.
Yeah, Dr. Manisha?
Yeah, we have to tell them that it is not a brain defect and it will not affect the neurodevelopmental outcome of the baby. So we can reassure them that irrespective of the size of the CPCs, slowly some of the cases will have a regression and they'll become normal. And we have to reassure the couple that it is not a neurodevelopmental delay or it is not a neurodevelopmental abnormality. So we can reassure and we can help them to get out of the stress.
Okay. So, Dr. Harshad, would you
Yes, ma'am.
advise some, welcome to the panel.
Yes,
and
ma'am. Yes,
thank
ma'am. I'm
you
here.
for listening in for so much time. So, would you advise any further testing on this patient? Or not?
Ma'am, if it's isolated choroid plexus cyst, then it's a benign thing. We don't have to worry. If there is an associated finding, like, if you see the clenched hand or something, some other associated important findings which are in association with CP cyst, then you need to go further for invasive testing. Whatever the finding depends on that. Otherwise, in this case, if it's isolated, you don't have to go for any other test, just a follow-up scan at 28 weeks, and also to see for the progression of the size or the disappearance of the choroid plexus cyst.
Okay, so you said one very important point, and that was that she needs a follow-up test.
Yeah.
I'm going to advise a follow-up test.
Yeah,
so you're going to follow the case at 28 weeks.
Ma'am, CP6 doesn't make any sense. Follow-up, it doesn't affect the neurodevelopmental outcome.
No, but if we see for the progression of the size, if suppose
no,
at
size
28
doesn't
weeks,
matter.
if you see the cyst, but we have to take a follow-up scan at 28 weeks.
Dr.
For the progression of...
We are gynecologists here, right? We are not fetal medicine specialists. So what I want to tell you is that if the mother is desperate, the parents are desperate कि कुछ तो हो गया है. So it is always better that yes, तुम 28 हफ्ते पे दिखा देना. It's better if you tell her that you come back and get reassured. It's not, you are treating 3 people here. Sometimes you are treating 20. The fetus, the mother, the husband, the mother-in-law, the girl's parents. So, if they see that everything has gone back to normal, I think that is, we become more legally safe that way, because a gynecologist has to look at a lot of things. It's not, this is guideline, she doesn't need anything more. Yes, Dr. Smita?
Madam, what I feel is that when such a patient comes for first visit, we have to see whether if she has undergone any kind of marker testing or sonographies earlier.
Yeah. Dr. Sarita already said that. Dr. Sarita already said that.
But if it is not done, then it is not done at all. If there is no testing, no double marker, then we can suggest NIPT also in such situations. That if she does not have any testing, because you have asked for follow-up, that's a good thing. But sometimes if the patients don't follow up, or there are any additional anomalies which come up which are not seen in this first scan, but there can be some evolving anomalies which come 28 week onwards, it is always better to get some testing in a non-invasive form like NIPT.
Okay. And Dr. Kirti, I want to ask you, do you expect any postnatal complications in this case?
Usually, no, ma'am, there won't be any postnatal complications. It is a benign condition only. So there won't be any neurodevelopmental delay as such for the baby post-delivery.
See, I have such a good panel that I want to make your life difficult. I'm asking you that this baby has delivered. Okay, you have assured that everything is good. Now the baby comes out without any complication. It's a painless, fast, normal delivery. And second day postnatal gets convulsions. So now what are you going to say?
So that can be attributed to the delivery, ma'am, maybe precipitated labor. So not just because of this EP cyst.
Or ma'am, there is a chances of perinatal asphyxia during the birth of the baby.
So how are you going to counsel the parents? Abhi, you want to save your skin, right? You want to save your skin from medical legal complications. Ki aapne to bola tha kuch nahi hoga. Yes,
ma'am, in that situation we have to see whether
absolute. The first rule of counseling is there's nothing called absolute. We can only say that the studies have shown that it has a good overall outcomes, but we can never be absolutely sure. there is 1% chance of if any of us having some postnatal conditions. This can happen to your baby also, but you do not have anything more than normal associated with choroid plexus cyst.
So the guideline, what I would like to add here for all us simple gynecologists is that you need to show data. When you are counseling them, you need to show data, because it is that data which you are going to hand over to them, which is going to keep you safe in the future, because you don't know what has happened. Anything can happen anytime to anyone.
Anybody.
Yeah. So in that case, keeping ourselves safe is important. And, you know, Dr. Reema has shown a lot of data. The simple genetic sonogram, the calculation, there are papers which I shared, which actually tell you what can go wrong and what is the percentage. And we need to show that data during our counseling. That would be my take home point. And Swati, as an expert, would you like to add anything to this case at the end before I go to the next?
No, ma'am, this is complete. Choroid plexus cyst is something we see every day, but it's not as simple as we take it. It's there are outcomes associated with it, though not very significant, but you have to take it in totality.
Okay. Okay. So now we proceed to the second case. Means it's numbered 3, but it is the second case. It's a 29-year-old Gravida 1. She has an echogenic cardiac focus in the left ventricle. There is no other positive finding, nothing at all. What are you going to do?
So, ma'am, again, we are going to go back if we are very sure that everything else structurally is normal and no other additional markers are present. We ask for a first trimester screening report, either in the form of a double marker study or a combined study, or an IPT, whichever the patient must have gotten done. And if she has it, and if that's a low risk, then nothing else is to be done. Patient has to be counseled that this, in such case, in a 29-year-old for her age, considering everything else is okay, is a normal variant and nothing else to be done. Even the guidelines say that even a fetal echocardiogram is not advised in such cases, because it does not increase the possibility of any structural defect in the heart also. So,
okay. So anything you want to add to this case, Swati?
Nothing, ma'am. Only thing I always, whenever I get a say, it's always wise to again review the scan to see if there are no other findings. Sometimes there are subtle findings. Look at the heart in lot of details. If everything is fine, a prior risk is low, this is not going to increase your risk to anything further. So you can just counsel the patient that this is a finding which can be seen in a lot of normal females. Your risk is not very high, but if you wish, these are the options which she has got a first trimester combined screening, that is low risk. Overall chances is very less. If not done, you can opt for NIPT in the second trimester or quadruple, depending on the situation.
Dr. Harshad, you wanted to add something?
Actually, no, nothing. I think whatever Pallavi said is absolutely right. I think it's a very benign finding and we can just let it go if we are sure that everything is normal.
Now, you have done a scan again at 36 weeks on this patient. Okay. And now you don't have just one echogenic focus, you have multiple.
Doesn't matter.
Doesn't matter. As long as we are sure that these are simply tiny echogenic foci, they are not more than 2 millimeters in size. We have to be sure that they are not rhabdomyomas. They are not soft tissues, but they are just echogenic foci.
That is what I wanted to know. How are you going to differentiate?
So, ma'am, the size is important in this case. We have to be sure that the size is not more than 2 mm. Whether it is present in left ventricle or right ventricle or atrium or single, multiple, nothing of that sort matters. Only the size, and it's visually so easy to spot that we don't even need to measure it actually. But
rhabdomyomas are very well defined kind of things. They are also very well picked up. Nobody can confuse between echogenic foci and rhabdomyoma. They are so well differentiated.
Okay. Okay. So now this is a thick nuchal fold and an echogenic bubble, which has to be the same echogenicity as bone to be echogenic, right?
Right.
Now we go to the next case. This is a Gravida 2 with one abortion. She's only 25 years old. Her BMI is normal. She had her first MTP done for renal pelvis of more than 20 mm and thinned out cortex of both kidneys at 18 weeks. Because right from her first trimester, the renal pelvis were much bigger, but at 18 weeks at the early anomaly, it was more than 20. Okay. Now this pregnancy, there are prominent renal pelvis at 12-week scan. Scan is repeated at 19 weeks. Both the renal pelvis are now 7 mm. Liker appears to be normal. There is no other anomaly detected. Now, what is going to be your course of action?
Definitely, we have to check her first trimester screening, ma'am. If the first trimester screening is low risk, we have to ask them that.
In the first trimester, everything else was low risk, but in the first trimester scan, normally you don't see the renal pelvis. They are not very prominent, right?
No, not very prominent.
She had renal pelvis prominent even in the first trimester scan. You could see them easily. 2 to 3 mm at the first trimester.
Ma'am, ultrasound examination should be done, especially of the contralateral kidney. And
both kidneys have
both the renal is
7 mm.
I think any
contralateral kidney, multicystic kidney, ectopia, renal agenesis should be ruled out. And if any associated finding is present, then we should move for amniocentesis and karyotyping.
I think this is a little more complicated than that. Swati will come to you in the end.
If she have a double marker with low risk, we will expect that it may be a structural thing. So we have to follow up the case like around 4 weekly to see whether if it is an evolving renal structural abnormality or if there is any progression of the pelvis. Accordingly, we have to classify based on the UTD classification, antenatally prognosticate the kidneys. And if both the kidneys are like having an increase in the renal pelvis, we have to like explain them accordingly. If the progression of the renal
7 mm. At 19 weeks, it is 7 mm. Normal is up to 5, right?
Yeah, that is a prominent pelvis. Even if it is 7 mm, some may progress, some may decrease to the normal. Even.
The patient wants an answer from you. What are you going to say? Abortion kara le ki rakh le? Now what?
Ma'am, we have to counsel the patient.
We have to follow up
continuation of pregnancy. Follow up the case in the 1 month after 1 month.
Rachita, you wanted to say something?
No, ma'am, I'm agreeing with all of them. Dr. Manisha and Dr. Swati, absolutely right. 7 mm at 19 weeks is prominent, but it only still means pelvic dilatation. We have not mentioned over here that the calyces are dilated. There's no features of...
Nothing has been mentioned about the kidneys other than the cortex.
Exactly. Just that means it could be an obstructive pathology, but it is not at all severe enough right now to warrant termination. It just means we need to follow up this case 4 weeks later, 8 weeks later, see what is happening to the pelvic calyces, see what is happening to the cortex. And we must be very clear with the patients that whatever may happen in the future, we can't jump and take the decision today. It could be a good progression, it could be stable, it could worsen. We can only take the decision as and when those things happen. And we can't, because she's had a previous bad history. That is why she'll be very worried about the same thing repeating. So but we have to make sure that they know that that time is needed for us to see how it is progressing. And of course, like everybody else said, if the first trimester screening is low risk and this is isolated, we're not too worried that it could be an aneuploidy. It's more than 4 millimeters, the likelihood ratio is still only 1. So we're not too worried about that. But please put them across to a urologist as well, so that they know that there are treatment options available also if it worsens.
Okay. So one thing you've made clear that aneuploidy is usually not there. Okay, it could be something structural. So would anyone want to, because the patient is very anxious, would you advise amniocentesis on this patient?
If it is isolated, then no.
First baby, nothing was done.
Ma'am, even then it was looking more like a obstructive pathology only. The thinned out cortex, the renal dilatation 20 mm, it looks more like a structural pathology only. And generally these structural pathology.
You got muted, Swati.
Ma'am, karyotyping should be offered only if other markers are present, otherwise not.
Not just for karyotype and markers, if you're suspecting a recurrent single gene disorder, that is again very, very rare in these
Very rare
obstructive
in a lower
pathologies.
urinary tract obstructive pathology.
Yeah,
It's
it's
very rare.
most often it is accidental idiopathic obstructive pathologies, which will not anything on a invasive test, ma'am.
Okay.
We won't pick up anything.
Do you expect any postnatal complications?
If it
Can be.
progresses, yes.
Depends. If it is progression, if it progresses, then it depends upon the type of progression. Like if it is an MCDK, it will not be dysplastic kidneys. We can't do anything. We have to, like, if they're infecting,
Right
then
now
we
the
have to remove
kidneys
the
are
kidney.
looking normal. The liquor is normal. Everything is normal right now. But it's only too early to say. It's only 19 weeks. Right. So
see how those pelvises are progressing, see what is happening to the cortex. If they're still maintaining good cortical parenchymal echogenicity, Liker is normal, prognosis is good. If in case the pelvises are dilating too wide, there's severe POJ obstruction, and also if the cortex is becoming thinned out, hyperechoic, Liker volume is dropping, then prognosis is guarded. And especially over here, if both bilateral pelvises are dilated, we must also carefully look at ureters and bladder, because it could be a lower ureteral tract obstruction as well, which is leading to bilateral pelviectasia. So only follow-ups will answer these questions, ma'am.
okay. So again, follow up and follow up. Anyone wants to ask? Okay. Now, and she's become now 38 weeks. Do you expect any kind of postcations, her thoughts?
So
Ma'am,
usually,
If the
cases even in isolated mild to moderate ventriculomegaly.
What did you say, please?
Ma'am, neurodevelopmental delay can be seen in 10% of the cases, even in cases of isolated mild to moderate ventriculomegaly.
Okay.
Absolutely, Dr. Sarita. I would like to add a point here, ma'am. Dr. Asha, ma'am.
Yes, ma'am.
Dr. Sarita very rightly said isolated lateral ventriculomegaly mild. But to call it isolated, we have to go through all the tests to rule out aneuploidy, CMA, chromosomal microarray is a basic test for any ventricle that crosses 10 millimeters at any gestational age. Even if nothing else is seen on ultrasound, it requires a chromosomal microarray, not a pure karyotype. It needs a CMA. It needs a torch serology, or if you're doing an invasive test, directly look for PCR of torch, and a follow-up neurosonogram at 26 weeks, because sulcatory landmarks come in only at around 26 weeks, 27 weeks. We are sure that the sulcatory landmarks are normal. So if all of these are normal, then we call it an isolated mild lateral ventriculomegaly. And as Dr. Sarita said, 10% can still have a neurodevelopmental deficit, even if everything else is normal.
So then what is going to be your counseling?
90% is good, so please continue.
Dr. Kirti, would you like to say something?
yeah, usually they have a good outcome. So apart from the 10%, so we will tell that if there is no progression and everything else looks normal on the scans, further scans, then there is a good outcome.
So the basic thing is you have to do a CMA. You have to do amniocentesis, send it for.
The first trimester screening test was low risk. Even in that case, the patient has to be offered a microarray because it is a strong marker. It has a likelihood ratio of more than 3. So that makes it a strong marker. So the patient has to be offered.
We want to micro deletions, micro duplications, which is why a microarray is required.
And ma'am, I also want to add that the risk of trisomy 21 is inversely related to the severity of ventriculomegaly. It's not like that if ventriculomegaly is very severe, then only Downs will occur. It is in fact inversely related to ventricular.
mild changes.
Yes, ma'am.
Swati, you have muted yourself and I can't hear you.
Rather, when the ventricles are more towards 15 or severe side, it is a structural abnormality rather than the mild ventricular variety. That one, mild ventriculomegaly is more associated with trisomies and other microdeletions rather than the severe ones. And irrespective of your first trimester screening or any kind of screening, this is a very strong marker associated with lot of other things apart from trisomy 21. You have to go ahead with amnio, and then also the story doesn't end. You have to follow and tell them at every scan if things are going fine. You have a better prognosis, but we can never be very sure. The risk of 10% is always there. Though that 10% is same as the general population, the long-term mental neurodevelopmental bad outcome is same in 10% of the population, but it is there. You cannot rule it out ever.
Okay. Okay. So anybody wants to add anything to this case before we
Ma'am,
proceed?
there are many patients who would want to know if MRI is going to add up to any information. So I think for such anxious patients, even though MRI has only a marginal superior, has superiority over ultrasound. Around third trimester, maybe an MRI can be offered to such anxious patients just to rule out small sulcation or cortical abnormalities, migration problems, which may have been missed. It's a breech presentation or something where we have not been able to do a very good neurosonogram. So in such cases, maybe MRI can be offered.
No, MRI has an added benefit in sulcation.
You've again muted yourself, Swati.
Again?
Remove your hand from that.
Again, MRI has some added benefit in cases of sulcation and migration disorders. Neurosonogram will not be able to pick some 10 to 15% of these disorders, and it is always wise to offer at around 32 weeks of fetal MRI. In severe cases, definitely, and in evolving cases, definitely.
I would say 26 weeks TVS neurosonogram, a good TVS neurosonogram will score over an MRI actually. Because the spatial resolution of a transvaginal neurosonography is much better than an MRI. However good the MRI is, TVS neurosonography cannot be actually replaced by MRI. Only like Dr. Pallavi said, if it's in a breech presentation or it's a very thick abdomen where we are not happy with our ultrasound imaging, then we ask for a MRI to rule out those certain number of sulcatory abnormalities. And again, a good TVS neurosonography in the hands of a fetal medicine expert is much, much more valuable than a fetal MRI done by a general radiologist. Because that again requires expertise to interpret properly.
Yeah.
Dr. Harsha, do you want to add something?
Oh, I was just actually saying the same thing what Ramamurthy madam said, that the position of the fetus is very important, because if it's a breech, then yes, MRI will score better if the expert is there behind that reading that MRI. And second, yes, even I've heard answers who does better either a fetal neurosonogram or a fetal MRI, whoever is expert, that you choose that modality accordingly. But yes, in terms of resolution, ultrasound in radiology has the best resolution. If you ask me, as per se a general question also, ultrasound has the best resolution in any of the imaging tests available. So if you have a cephalic presentation, you go by a TVS scan, you are an expert, then obviously it's going to score more than an MRI.
Come on, now we have 4 more cases to go and we have 15 minutes. So let us really take them fast because I have to end the program by 7:30. So this is a Gravida 1 para 0 24-year-old. Mid-trimester scan done at 20 weeks. Spina bifida with tethered cord was reported. What's going to be your course of action? This is at L1 level, okay? This is at L1 level. What are you going to do?
Is it an open spina bifida or a closed spina bifida?
Open.
Okay.
An open spina bifida, 20 weeks, L1 level, tethered cord.
Okay, if it is an open spina bifida, definitely we'll see signs of cerebral, Chiari malformation.
You
And,
have seen all that. The question is, what is going to be your course of action? You are a
definitely it is a
gynecologist. What are you going to say to her?
we have to clearly explain them that it is a there will be a protrusion of the brain into the spinal cord. So neural neural effect will definitely happen to the baby. Lower limb paralysis, incontinence to the bowel and bladder, all the sequelae has to be explained to the couple, and we have to clearly tell them that there is a surgery available in utero, but it is not that expertised in India. So anyway, we can't give an option of antenatal surgery. So postnatally, we have to postnatally, the prognosis will depend upon the brain parenchyma affected and ventriculomegaly, which is happening, and definitely it is a guarded prognosis. We have to explain them clearly the consequences, incontinence to the bladder, bowel. Also, if there is protrusion of the pons into the spinal cord.
See, it is a to say something. This is Sir's area of expertise.
A tethered cord and the defect per se, whatever the neuromuscular sequelae can be rectified postnatally. As doctor said, the intrauterine surgery is still in research phases, even abroad, not just in India. So, the management intrauterine is still very, very in its early phases. Postnatally, surgery is required. And corrective surgery can be done, but even after corrective surgery, residual problems like incontinence, strength, paresis, it may not be complete paraplegia, but paresis could be a problem. So for all of this, all of these questions are best dealt with by a neurosurgeon, not by the imaging specialist, not by the clinician.
Now this patient is asking you this question. I want to ask Dr. Vidya, are you there? Vidya, I want to ask you this question that the patient is asking you, Madam, you tell me whether I should abort or I should continue. If you were in my place, what would you do? Patients will blackmail you like that, no? So what side are you going to be on? What are you going to say to her?
Dr. Sarita, Dr. Smita.
We will refer to Madam Neeru. I would like to take shared decision. If the patient is not willing to continue this pregnancy,
she is saying कि मैम आप जो बोलोगे कर देंगे. So now what are you going to say?
Madam, amnio and termination.
Neurosurgeons, madam.
Ma'am, why amnio? What will you find in an amnio?
Madam, we will take the suggestion of neurosurgeons.
See, amnio in a case of open spina bifida has
no role.
No role.
What would you do? But I tell them it's not my baby. I cannot say whether I will continue or not because it is not my baby. We give you all the information. This is the data. These are the options of treatment available. Whether you want to continue or not is totally up to you because you are the ones who are going to take care of this child after birth. Nobody else can make that decision for them, and nobody else should, in fact.
Exactly.
It should be a total non-directional counseling.
Okay, so here the most important thing is that amniocentesis has no role. We should counsel this patient to take folic acid before she plans to conceive next time. She should
This
be
is one thing very important.
3 months before she is trying for pregnancy, she should take folic acid. And this pregnancy continuing or not continuing is totally her decision. Okay?
Exactly.
Now, anybody wants to add anything to this or we go to the next?
Ma'am, next.
Okay. So now this is a 35-year-old. She is gravida 3, para 1, living 1 and has had 1 abortion. Mid-trimester scan done. She's come directly for the MTAS. She has never been to a doctor before. You know, up
one baby is fine, so we're not really worried. And now you see a big omphalocele. What will be your course of action, your counseling, your testing?
Ma'am, basically, omphalocele, we have to see the contents of the omphalocele. As you told, it is big. So we have to see whether the liver involvement is there or not, because liver involvement has a poor prognosis. And it is usually associated with other structural defects as well as genetic and chromosomal abnormalities. So we definitely have to offer her amniocentesis and do testing because of its chromosomal involvement. And we have to tell her regarding if the size of the omphalocele and if the liver is present or not. And we have to explain her like regarding the testing. And in case if she wants to continue, we can tell her like the postnatal corrections are there, but based on the involvement of the liver, if it is there, then the poor prognosis.
The results. Is that okay? Now,
Yes,
what
ma'am.
we get, whether it will happen again in the next pregnancy, that will depend on the reports that we get.
Reports too.
So
Yeah.
is there any role of parental testing? Because usually when they have one healthy child, they are, we were normal. That is how we got one healthy child.
Ma'am,
So
there is
we
a
suggest parental testing if something comes wrong in the amnio report.
Amnio, again, we are going to do a chromosomal microarray and the choice of either a whole exome sequencing directly or store DNA, and if CMA reports come normal, then do a whole exome on the stored DNA. And if something comes out of the whole exome sequencing, like a single gene disorder, then only we will be checking the parents. Otherwise, if the whole exome is normal, there's no role for couple screening.
Okay, but then they should be able to go through those steps, right?
Yeah, yeah.
Ma'am,
Agree to go through those steps. Yes, Swati?
ma'am, directly parental testing is always very risky. What are we
We are doing the index case. We are doing
Huh.
the index case. Agreed. But how much are you going to do was my question. So CMA, if CMA is negative, then whole exome. If you get something, then parental testing. Right?
Yes.
Now, supposing it is an isolated omphalocele. Supposing. What are the chances of her future?
I mean, isolated case, there is no increased risk.
Okay. So means see that you're saying no increased risk is fine, but half
In
her
future
bowels are
pregnancy.
lying outside.
No, in the future pregnancy or for that
No,
fetus?
in this pregnancy.
Oh, in this
what is the
pregnancy.
risk to
Okay,
the
okay.
baby?
Ma'am, I was talking
during
about the future
delivery,
pregnancy.
post delivery? What is the risk to this fetus?
There might be a
All of
rupture
that
that omphalocele. They can, because of bowel obstruction, they can have a polyhydramnios that can cause preterm delivery. So these are the main prenatal problems they can have, ma'am.
So we'll have to counsel the patient that it all depends on the size and the content of the omphalocele. If the size of omphalocele is too big, it means so many structures have gone inside. If there is liver inside, then of course it is going to add to the troubles. And also, larger the omphalocele, more it compresses on the chest also. So the child has a chance of having hypoplastic lungs and breathing difficulties, swallowing difficulties also in future. So all these things have to be told to the patient before they opt for any of the options, whether termination or whether continuing with the pregnancy. Only then they can have the correct direction of what they're going to be doing.
Okay, Dr. Manisha, would you like to add something?
No, that is what I'm doing.
Again, omphalocele is an evolving anomaly. What we see at 20 weeks may not be the case at 24 weeks or 28 weeks. It can grow larger and larger. Like Dr. Kirti said, it can rupture. And if it ruptures, the bowel loops will be exposed to amniotic fluid and can have necrosis. And that can complicate postnatal repair. It can involve resection of quite a few loops of bowel.
So to my gynecologist, would your counseling be more in favor of an abortion?
Again, non-directional, ma'am. Wait and watch.
Okay. So this is one case. This is Dr. Rachita's case, which is showing all long bones are short. She's 34-year-old. She has one healthy baby, and now all long bones are around the 10th centile. What does this mean? What's your course of action and counseling?
First thing we need to do is we need to check all the bones.
Yeah, you've
along with
done
the
all
rib
long
case.
bones are short.
Yeah, along with long bones, we need to check the rib case, and we need to check the cranium. All the bones have to be checked thoroughly, and we have to tell them that it can be a chromosomal abnormality or a evolving skeletal dysplasia or an IUGR baby. So in this particular case, better to take a umbilical Dopplers to see whether it is an early onset IUGR.
So 10 centile is something
normal.
that we are not concerned of.
Yeah,
as
less
of
than
now.
5th
Because
centile
the
is
normal
concerned.
All
but
her other parameters are above 60. Only the bones are at the 10th centile.
It's a
Even
warning
then, it
alarm.
could be a short-statured couple. It could be a familial
Completely
variation of just a stockily built fetus, which is normal. So at one single point, if we are seeing 10th centile, we really should not worry. At 10th centile, we won't even trigger off any other tests. We won't even ask for any other invasive tests. What is important is to trend. Wait for another 2 to 3 weeks, measure all the long bones again. See
that
the
was the
trend of
point I
growth.
wanted to bring up in this case. That if it is the 10th centile, don't trigger anything, but make a note to yourself and follow up the patient in 3 weeks. Because for any size anomaly, you need to actually have a trend. You need to have a trend. Unless you have 2 or 3 parameters, you cannot predict, yes, this is short, this is long. You don't compare the head with the femur. Because invariably, when you're doing the scan in the Hadlock chart, when you're measuring the BPD, it is always a higher centile than you get for any other thing. Anyone wants to add anything?
That's
Anyone
enough.
wants to add? No? So we run to the next case. You've done an MTAS, G5 para 1, living 1, and 3 abortions. Okay. They are all induced abortions because she didn't want the pregnancy. Nothing, we don't know and have any details of that. You see a double bubble sign, the duodenal atresia. Now what are you going to do? What is your course of action, your counseling? What testing are you going to do? How are you going to follow up this patient?
Ma'am, she has already taken decision of MTP in last 3 pregnancy. And if she do not want to continue in this pregnancy because it is a case of duodenal atresia, she can
This time
opt.
she wanted. This time she wanted. So she has come at 20 weeks directly. She has not come to you before. She's just come directly. कि आप 20 weeks हो गया, आप दिखा लेते हैं.
Duodenal atresia is one of the anomalies which is very, very strongly associated with Downs. So the first thing we need to rule out is Down syndrome by directly doing an invasive test. And again, since it is an anomaly, we'll do a chromosomal microarray rather than a karyotype alone. And if that comes normal and if all the rest of the fetus is normal, then the choice is up to her. She can continue and get a corrective surgery done, pediatric surgery to repair the duodenal atresia after birth.
See, there is one thing, there is a duodenal atresia. So you do not know the state of the bowel after that.
Yeah. Multiple atresias we cannot rule out.
You cannot rule out anything that you have seen a duodenal atresia, but you're not able to see what is happening after that. Because I had a baby who was diagnosed duodenal atresia and they decided to continue that we'll have one surgery. But by the time 7 weeks was there, her whole bowel was, like that with a bit of meconium, and it was all short balloons with intervening tracts. And we finally lost that baby. So all this has to be part of the counseling. So we need to do an amniocentesis, do the testing, and then leave it actually up to the parents to decide what they want to do.
And also counsel them about polyhydramnios that will develop later.
Yeah. Okay. So now we come to the take-home messages. I request everyone one by one. From this webinar, what are your take-home messages? And then we can end the session. Because we spent 2.5 hours here. We need to learn something.
We will look for the centiles also, as the Dr. Rachita said. That is the one thing.
Okay.
Ma'am, I learned the anomaly scan should be done between 20 to 22 weeks because we were not aware that it should be done 20 to 22 weeks, and it is more informative at that gestation age because we were doing it from 18 to 24 weeks of gestation.
Okay. Dr. Vidya?
Yeah, I have told Madam centiles. I should go for the centile as Dr. Rachita said. That is the good thing.
Dr. Smita?
Counseling from the patient point of view. And then whenever patient tries to say what you will do in this situation, so you clearly clean yourself that I am not the part of this situation. That's what I liked very much. Rest all the things were really impressive.
Dr. Pallavi?
Ma'am, even I agree with ma'am that non-directional counseling is something that's because many times patient puts so much pressure on you that you tend to, thoda kuch to direction mil hi jata hai.
Yeah.
But as clinicians, you have to keep in mind, you have to have a stone heart and, it's a choice of platter should be there, it should not be ours.
Dr. Manisha?
Like if we see any structural abnormality or any minor markers, like minor markers can be dealt, but in a structural abnormality case, better to involve a multidisciplinary team so that the patient will be having a clear-cut view regarding that particular abnormality, and they can easily decide what to do.
And also, we are sharing our burden. The entire burden does not fall on one doctor. When you involve other doctors, the onus is shared by everyone.
Dr. Kirti?
Ma'am, regarding the transvaginal ultrasound is better than MRI for neurosonogram. So I thought for cortical malformations. So
yeah. So Dr. Swati is not here anymore. Dr. Rachita, I would like you to end it because you have given us so much information. I don't think you learned anything, but how you...
No, I learned a lot because we rarely get to see the clinician side of the story. A lot of patients ask us also, but for us it is still easy saying we have explained to you, but you ask your doctor. You ask your doctor is an easy way for us to get out of it. But yes, it is difficult. Counseling is hard, and it has to be like Dr. Kirti said, everybody has to work together, not just during the scan and after the scan, even before the scan. What y'all want, if you convey to us, we need to put in that much extra effort to clarify those doubts. And also, of course, we have to call, we have to discuss those points with y'all so that the message that goes out to the patient finally is clear. Thank you so much, Dr. Asha.
Bimal sir, are you there? No. So, thank you so much. Thank you for being here. I hope you enjoyed it as much as I have. I really refreshed myself. Yeah. And I've been sitting here 2.5 hours without moving. So it was spellbinding to me. Thank you, thank you, thank you so much. Dr. Rachita, Dr. Reema, Dr. Bimal Sani sir, Dr. Jayam Kanan ma'am, and Hassan Haveri, Jalna, Bhimavaram, Jammu, Jaipur, Jamshedpur, Jhansi Obstetric Gynec Society, and SFM Chhattisgarh, and all my delegates who have listened in. I also thank Corona Remedies, who has been our academic partner. Thank you for all the support. Namaskar.
Thank you, ma'am.
Thank you so much. Thank you.